questions in my possession, so I'll just take questions from the audience. Just mention one bit of new research I found interesting. A paper just came out that showed that treatment of Parkinson patients with levodopa, or Cinemat, results in enhanced creativity. And the study is interesting because it measures creativity kind of objectively. And I've always had the impression from many of my patients who develop Parkinson's disease that they start painting and they do paintings that are really interesting that they hadn't known they could do, or other realms of endeavor, but especially with the painting and drawing. And I thought that was interesting. I wonder how many of you, after you were diagnosed with Parkinson's disease and were given medication, began to paint? Probably none. Well, anyway, that's in the literature. I found it intriguing. There a lot of the paintings here were done by someone who is a painter, and probably, but she was creative even before.
I've been working at this for, like
all your life.
45 years as well.
Yeah, you don't feel that the use of levodopa gave you a little extra impetus to, or no?
It's kept me going.
Yeah, okay. So if you're already an artist, it doesn't count. Okay. All right, I'll take some questions. If there are no questions, I'll ask some questions. Why do people think when they're diagnosed with Parkinson's disease that this is the end of the world? One of the things that I'm often asked about, I have Parkinson's disease, what's that mean for the future? And will my lifespan be shortened? Will it affect the quality of life? And what's really interesting is how to answer that. And the way I answer it is based on the facts that are published about Parkinson's disease. The lifespan of individuals who are diagnosed with Parkinson's disease was remarkably short until the levodopa era. Since 1960s, when levodopa was introduced, and we learned about the dopamine deficiency that underlies Parkinson's disease, the lifespan is exactly the same as people who don't have Parkinson's disease. So it doesn't shorten your lifespan. And so that's the one bit of information. Not only that, one doesn't see a lot of the things that happen to Parkinson's patients before the era of levodopa. And one of those things was fixed forward posture, completely forward, bent over like at right angles was the common final posture that developed. And we don't see that very much anymore, because as soon as the levodopa is taken and dopamine replacement, the muscles aren't as rigid continuously, and so the natural tendency of the illness to cause rigidity and flexion is attenuated. Now, some people do develop serious stoop posture, but it's just not as bad as before. So the mobility is the major issue with advancing illness. Initially, a little bit of slowness and rigidity in an extremity can be handled with medication, but with time, balance becomes an issue. And that's the one area that we have to really work on. Because once balance becomes a problem and people start falling, that is what interferes with the quality of life. You lose independence. The fear of falling, it becomes a serious factor that hampers your ability to do things on your own. So the biggest challenge, well, there are a number of challenges for the future of Parkinson's disease. One is to find a way to prevent this falling, this postural instability. And luckily, well, before I say luckily, right now there's no medicine that we have that will prevent falls. There's no medicine that's going to decrease the probability of falling with a provision, with a proviso. To the extent that your falls are related to slowness and rigidity, that's about how much improvement you would get with levodopa. But a lot of falling is not related to slowness and rigidity, It's just loss of a postural reflex. The ability to recover when one's center of gravity is shifted is lost in this illness. And it's not due to dopamine deficiency. That's why levodopa, well-managed schedule of levodopa dopamine agonists will not prevent the falls. Many of you are in wheelchairs that use walkers are on good doses of levodopa. You have very little rigidity and slowness in the extremity, and yet you'll still fall. So there are two approaches to solving the falling problem. One is to prevent the illness to begin with, but we don't know how to do that yet. Second is to develop a medication that works differently than dopamine that will improve gait and balance. And there is a lot of work on that. There was a drug called L3-adops in the mid-1980s that was being tested. And a Japanese group of researchers published a report that this drug was very effective in improving postural instability. And it was very exciting because it would be the counterpart to dopamine for slowness and rigidity. Now we have 3-adops for falls. And so the study was, the drug was studied in Sweden by one group and in New York by Stanley Fawn at Columbia. And I remember one of the first international meetings I attended, I was just training as a movement disorder fellowship. And it was a big disappointment that those two other studies, the European and the American study, failed to replicate the Japanese findings. And Stanley Fawn said very dryly, it appears that this drug, the L3-adops, is very good for falls and postural instability in the Japanese. But in the Swedes and Americans, it doesn't work. And unfortunately, so that's where we are with medicines there. You can ask questions after I give you my little overview. So the second approach, there's something to it though. There was some bit of correctness there in that L3-adops is replacing noradrenaline in the cerebellar, in the brainstem. And it appears when that's deficient, there is a tendency to fall. So they're developing similar type drugs. They're being looked at to see if they could be useful for the postural instability of Parkinson's disease. And the other approach, which is experimental, but it involves deep brain stimulation, and it's based on animal work that shows there's a region of brain a little bit deeper down than the substantia nigra called the PPN. Anybody who wants to practice their memory and their language, you can say this over and over and I'll test you later. Pedunculopontine nucleus.
Yeah, right.
Yeah, why not? Pedunculopontine nucleus, PPN. Stimulating that area, making it fire a bit better, will improve gait and balance in animals that have been rendered experimentally to lose their balance. And so that was taken to humans, first in Toronto by Dr. Lozano at University of Toronto, and recently in Gainesville by Dr. Foote and Dr. Oken. And they find that putting DBS electrodes, a pacemaker, to the PPN, pedunculopontine nucleus, improves gait and balance and decreases the frequency of falls. So that's kind of exciting, but that means now if you're going to go the electronic route, bionic route, semi-robotic hybrid route, we're going to have like 4 electrodes in the brain. And so for me, I don't like that. I don't like electrodes in the brain because of complications and getting them there and all that. So I'm still looking forward to the development of medications for gait and balance. The major reason, there are 2 major reasons people end up not being able to be at home and require nursing home placement or 24-hour nursing care is the stage when you lose your balance and fall. And if we could prevent that, people would be able to remain independent for a much longer period of time. So that's one of the major goals for this, the development of new medications, to prevent that final, that stage of the illness called loss of postural reflexes. Such an important phase of the illness that we call it the transition from the first two stages. Any of you who sees me will know the first stage means you have signs on one side of the body but not the other. Stage 2 is when the illness is involved both sides of the body. In stage 3, that transition stage is when you're beginning to lose postural reflexes, meaning you're starting to lose your balance. You're likely to fall. And 4 and 5 are stages after that, which is you're wheelchair bound or you use a walker all the time. And stage 5 is, even with assistance, it's very hard for you even to transfer and so forth. Okay, there's a question.
Yes, sort of twofold. Number one, what area... It's sort of twofold. Number one, the first part of the question is there a specific part of the brain that controls balance? And then the second part of the question is, when I think of alcohol and addiction, people lose their balance. You know, we say they're plastered and lose their balance, or on some kind of drugs. So.
There's no one part of the brain that controls balance. It's a network. It's a very multiple systems. It involves cerebellar pathways, which we know are the back of the brain involved in rhythmic and rhythmic movements, timing, and so forth. It involves the basal ganglia, which is a complex network that gets information from below, sensory information, feedback information, from the frontal lobes that have all the programs for the automatic execution of the movement. And there's all these loops going on. That's why it's so difficult to know how to treat. Many lesions in any parts of the brain that are part of the network for maintaining locomotion and balance can cause falls. Simple. You start with the muscle. You're going to fall if you have a weakness in the leg. So think of it. All the different things that cause you to fall. It's not just there. If you have a small stroke, results in hemiparalysis, well, your chances of falling are great. It has nothing to do with the basal ganglia, but with the final outflow of movement. Well, let's say you have lost all your sensory input to the brain. You have really bad peripheral neuropathy. You're going to fall because you don't have feedback for where your body is getting in to put that information into the brain where it can be integrated into the plans for movement. Now, many drugs will cause loss of balance, staggering gait and falls. And it's because it disrupts many of the systems, not just the ability to maintain balance. People without Parkinson's disease who get to be 90 years of age will also, they have no slowness or rigidity, maybe a little slowness, but they're not rigid, they have no tremor, but they fall. It's one of the major reasons people end up in hospital, fractured hip from falls. Even without Parkinson's disease, the chances of falling as we age increase. Why? Because there are 3 systems that we maintain our body in space, our orientation in space, stably on your, and to maintain a stable balance. One is the proprioceptive system, which is a sensory feedback from the bottoms of your feet. There's nerve endings. There are nerve endings in your muscles, nerve endings in your joints that send information up to the brain, up to the thalamus, where all sensory information is integrated. And from there, it goes to the basal ganglia, those gray matter structures of which the attention nigra is part of, to cerebellum. And that tells the body, tells you unconsciously, because you're not even aware of it, all happens automatically, that your leg is raised, right? It knows, it will know and adjust accordingly. But if you don't have that sensory information, your body won't be able to adjust because it doesn't have the information upon which to work. So that's one of the reasons. And usually if you lose proprioception, that's called position sense, there are other systems that make up for it, compensate. Your vision. So even if you have position sense, at least your vision tells you where your body is in space. So that helps protect against falls. And the third is your vestibular system, which is like this gyroscope that automatically tells your head and your body where your body is in relationship to gravity and whether you're moving or not. It's that inner ear thing. So if you have inner ear problems and you're losing your hearing and you're losing the function of your inner ear. And you're getting old and so your vision is bad, and you have peripheral neuropathy. So all those three systems are gone. As happens as we get older, one is going to fall. So that question you ask, where the brain is balance maintained, the whole, many networks are involved in sensory system, motor systems. The sensory systems are visual, inner ear, and peripheral neuropathy. The motor systems are the frontal lobes that store all the programs for automatic action, the basal ganglia that integrate all the sensory motor information. This is much more than you needed to hear. But when you ask a simple question, you'll get a complex answer.
Well, I wanted to ask you about last month, April 28th, in Vienna, there was an announcement made, a European consortium, a top expert, and they developed a therapeutic vaccine against Parkinson's and multiple system atrophy. I wonder if you can tell us more about it, and if US is going to be part of the experiment.
Well, we actually have a lot of information about vaccines. At University of South Florida, the development of a vaccine, which is developing antibodies that will react against an abnormal protein that's usually due to a viral protein or bacterial protein. So that's how we vaccinate people. First vaccinations were smallpox. You get weakened virus, or you get the cowpox, which is similar to humans. You inject it into your skin and you develop an immune response. So the next time you're exposed to that invading bacteria, you can get rid of it. You react to it. Your defense system, cellular immune system. It's not only cellular but also humoral, because their antibodies are not in the cells. They're released into the bloodstream in the plasma. So that's the immune system. And the immune system was being harnessed to treat Alzheimer's disease. And that was the first big breakthrough to use vaccination against a neurodegenerative disease. So antibodies were developed against the Alzheimer's protein called beta amyloid. And in mice with Alzheimer's, it was amazingly effective. The animals did not develop the Alzheimer's if you gave them either the two ways that you can vaccinate someone. Passive immunization is where you take the antibody that's already been generated in, say, a rabbit. You inject the abnormal protein into a rabbit multiple times. You collect the antibodies from the rabbit, then you infuse those into the mouse, or in the human, as was later done. Those antibodies will recognize the abnormal protein and clear them using the immune system. That's passive immunization. Or you could inject a person with a mutated alpha-synuclein multiple times, and they develop an immune response to that alpha-synuclein, and it would lower amyloid in brain, the beta amyloid, the abnormal protein. And it worked well, it seemed well, but the problem is people developed encephalitis and very bad reactions to the immunization against amyloid. Finally, they developed a better way to immunize, and they could prove that there was a big diminution of beta amyloid in the brain of Alzheimer's disease, because you can visualize the beta amyloid with PET scanning. So you can see the amyloid burden was decreased, but people continued to be demented. So now everyone is questioning, well, what all of this effort to develop a vaccine against the abnormal protein that develops in Alzheimer's appears not to be improving the disease itself. So therefore, that beta amyloid was not the cause of the illness, but nothing but kind of a gravestone, a marker of the disease process. So all the vaccine did is clear the cemetery of the gravestones. It didn't do anything to the disease. So similarly, antibodies were being developed against alpha-synuclein. That's the abnormal protein that accumulates in Parkinson's disease. And in mice, it worked well. In fact, the Parkinson Research Foundation, in one of the last grants they funded a Dr. Chow, who was a colleague of mine, to develop a vaccine against the Parkinson's Lewy body, which worked really nicely in the mice. We published the abstract on it. And there's other people in Europe are claiming they now have this vaccine But the problem is that vaccine is directed against alpha-synuclein, which is not the cause of the disease, but is a wave-stand, it's a bystander, maybe the tombstone. It's a marker of the disease process rather than the cause of the disease. So even if you lower the beta amyloid, it probably is not going to stop the disease. So that's a disappointing thing. In mice, it works beautifully because mice don't lose neurons. In other words, they have they don't lose neurons like Parkinson's disease. So we can create a mouse model that's similar to Parkinson's disease. We put a gene for alpha-synuclein that's mutated, they accumulate alpha-synuclein, but they never lose the neurons. So I'm not that hopeful about a vaccine for for Parkinson's disease, because the big question is, it's directed against alpha-synuclein in Lewy bodies, and that really is not the cause.
Okay, so if alpha-synuclein is not the cause, what is the cause? That's still the question, or we still don't know?
Yeah, it's probably the bits of the alpha-synuclein protein that haven't polymerized yet to form the inclusion. Now, when we talk about Lewy bodies, it's something that you can't digest and accumulate in cells and causes it. We used to think it caused the death, but we see it in cells that are not functioning well. But what probably it's doing, the alpha-synuclein, is kind of cleaning up and gathering the small bits of the mutated alpha-synuclein, which are small segments of protein, into big old polymers of protein. So it's kind of the garbage bag of the small toxic materials that are creating the damage, that are creating mitochondrial damage, are not these great big inclusions called Lewy bodies, but the alpha-synuclein mutated peptides. The same thing with Alzheimer's. They don't think it's the amyloid plaque, but it's the oligomers. Let me tell you something about polymeric chemistry. Think of it this way. A protein is nothing but a chain of amino acids. You can think of it as a pearl. A pearl is an amino acid. You have a whole string of pearls, that's a protein. But we use 20 different amino acids. So imagine a string of pearls with each pearl being a different quality. Some are blacks. So that's what a protein is. And small segments of those pearls, are called peptides. Polypeptides are the proteins, but what happens in beta amyloid, it's a protein, but it's mutated. Instead of a nice string of pearls, there's a few really weird rectangular chunks there that shouldn't be there. And so that's what's toxic. The fragments of amyloid or fragments of alpha-synuclein are toxic. And what the body tends to do is gather them up and make a polymer and tie them up so they don't affect the cell. So it's kind of like a marker of how long you've had these toxic circulating materials. So theoretically, if you could develop a vaccine against the mutated synuclein before it polymerizes, then it might work. Do you understand the difference between clearing the Lewy bodies or clearing amyloid versus clearing up the small toxic peptides? That's the key. Now, if they can claim, this is not the first claim I've heard of successful vaccine against Parkinson's disease, but we'll see if it ever gets clinical trials.
What about GDNF receptors?
Well, GDNF, there's a number of gene therapy studies, where they're putting in the gene for GDNF into the brain of Parkinson patients. It's actually neuroturin, it's a related gene. It's a growth factor. We know that growth factors decline in the corpus striatum and dopamine neurons die. In an animal model, if you put in the growth factor by injecting it in, the neurons re-sprout. And so what the goal is by a group called Serogene is to put in DNA inside a viral vector that encodes a growth factor. And those are in clinical trials. Some reports show that they haven't met their endpoints. They haven't been as successful as they like, but they're claiming it's safe. Because previous studies where they infused the growth factor itself, not the DNA or the virus, resulted in an encephalitis, kind of a global brain inflammation. So those studies were halted. Now they're doing it differently. But you know what? You can achieve the same effect as that gene therapy by exercising 5 days a week, 3 days a week, getting your heart rate up to 80% of max, and those same growth factors that we're trying to put into the brain are elaborated and increased in the glial cells of the striatum. So, and that's been demonstrated. So I would say get into a really good cardio aerobic exercise program before you volunteer to have viral vectors put into your brain.
Ladies first.
Can you talk a little bit about the differences between traditional Parkinson's disease and atypical Parkinsonisms?
That's a classic question. I hope everyone will listen carefully, will never ask me this again. It's a classic question, and the students I talk to, the first thing we say is Parkinson's syndrome versus Parkinson's disease, which is often said idiopathic, and then atypical Parkinson's. So there are three concepts here. They're all related. Parkinson's syndrome is just a collection of signs and symptoms that people with Parkinson's disease exhibit. But there are many other conditions besides Parkinson's disease, which is a pathological process, to develop a Parkinson's syndrome. The common Parkinson's syndrome, let me tell you what the syndrome is. There are 4 signs and/or symptoms. Slowness of movement, difficulty in initiating movement, that's one, called bradykinesia in Greek, slow movement. Second is rigidity. Patients often won't notice that they're stiff, but the doctor, you see, says, you got cogwheel rigidity. It's a very special type of rigidity. And usually begins on one side first. In fact, it has to if it's Parkinson's disease. But Parkinson's syndrome may have it begin on both sides. So the Parkinson's syndrome has slowness of movement, cogwheel rigidity. The third sign would be rest tremor. Now, different than action tremor, kinetic tremor, postural tremor. It's a tremor at rest. And the fourth cardinal sign is loss of postural reflexes. Parkinson's syndrome is said to exist if 2 of those 4 signs are present in a patient. So if a patient comes in and I see they're very slow in their movement, they have no tremor, they're not falling, and I know cogwheel rigidity, I say, you have the Parkinson's syndrome. I haven't said he has Parkinson's disease. I haven't said it's atypical. Parkinson's syndrome is the phenomenology. It's what the doctor sees and on exam, and what he gathers are the symptoms. Symptoms are what the patient says, complains about to the doctor, signs are what the doctor finds. So Parkinson's syndrome, most people that come here have a Parkinson's syndrome. Now how do I know whether it's idiopathic Parkinson's disease versus atypical Parkinsonism or secondary Parkinsonism? So I'll talk about idiopathic. And this is a disease that has a Parkinson's syndrome that began on one side of the body, that progresses gradually to involve both sides of the body, and that responds to dopamine replacement. And pathologically, if you look at the brain of these people, and I'm talking about idiopathic Parkinson's disease, you'll find the loss of dopamine neurons in the presence of Lewy bodies. That's the definition of idiopathic Parkinson's disease. And idiopathic means we really have no cause. That this person has Parkinson's syndrome, we cannot have a cause for it. Idiopathic is a pathological term that refers to the fact that the cause of this condition is unknown. And 80% of the cases that we see with Parkinson's syndrome have no known cause, and that's idiopathic Parkinson's disease. The way you can remember, my students like this, the doctor is an idiot, the patient is pathetic. If you don't know the cause, it's idiopathic. That's it. It's idiopathic if you don't know the cause of the Parkinson's syndrome. And that's what Parkinson's disease is, idiopathic. That's the majority of the cases. They begin on one side, it becomes bilateral, they're slow, they're rigid, have intermittent tremor, and with time they begin to fall. And they get better, slowness and rigidity-wise, with dopamine replacement. That's Parkinson's disease. And if you really want to be 100% sure, you ask them for their brain after they die, send it to the pathologist. Nowadays, you can actually look at dopamine innervation and see with the DAT scan, but That's tricky because you can see that decrease in atypical Parkinson's, which moves us to the other one. Atypical Parkinsonism are Parkinson's syndromes that have other features besides slowness of movement, rigidity, rest tremor, and loss of balance. It has other features. For example, they may have spasticity, called an upper motor neuron sign, and that is very similar to the spasticity you would see in, say, a person who had a stroke. They have hyperreflexia, a different kind of rigidity, and the most important thing is pathological reflexes, where if I tap the knee, it goes like that, and it spreads. So if I have someone with Parkinson's syndrome and I do the exam and I see they have hyperreflexia, I say they have an atypical Parkinsonism, or they have Parkinson's syndrome and happen to have had a stroke, or cervical spondylosis, and spinal. So that's atypical. You have other features on the neurological exam that don't exist in idiopathic Parkinson's disease. Other atypicals are when there's a lot of cerebellar ataxia, where they have rest tremor, slowness of movement, rigidity, and they have really marked oscillation when they go to do things. Postural tremors are very severe. That's not typical for idiopathic Parkinson's, so that's an atypical. Another atypical would be the progressive supranuclear palsy. These atypicals are also known as multiple system atrophies. Let's think of it that way. MSA is equal to atypical Parkinsonism. And that includes, for example, where Parkinson's syndrome, where the autonomic nervous system is markedly involved way before the slowness and rigidities is a serious problem. That's called Shy-Drager syndrome. And these people suffer from intense low blood pressure. They sit up, they practically faint, marked constipation, marked bladder problems, problems with the autonomic nervous system far outweighing the Parkinson's syndrome. That's called Shy-Drager, another atypical Parkinsonism. The progressive supranuclear palsy never has tremor, presents with axial rigidity and impossibility to gaze downwards, upwards, or horizontally, so you have to go like this. And that's also an atypical Parkinsonism. Now, these atypical Parkinsonisms may have some dopamine deficiency. So they also will respond to dopamine, but after a little bit, you notice they're not as effective. The dopamine is not as effective in treating the condition. So that's atypical Parkinsonism. And then secondary Parkinsonism, the most common of all Parkinson's syndromes, are drug-induced Parkinsonism. If it wasn't for drug-induced Parkinson syndrome, we wouldn't have discovered the dopamine deficiency story. And that is drugs that block the action of dopamine in the striatum will mimic idiopathic Parkinson's disease. It looks just like Parkinson's disease. And if it wasn't for the study of Julius Axelrod in the late 50s of the major tranquilizers like Thorazine, Haldol, that were revolutionized treatment of schizophrenic patients in the 50s, well, he was studying how Thorazine worked because Thorazine produced a syndrome of Parkinsonism in schizophrenics. So schizophrenics were given to trials initially of Thorazine. They were in their 20s. You know, schizophrenia is a young disease, so to speak, young adult disease. And they had stooped posture, small stride, decreased arm swing, tremor, salivation. They looked identical to Parkinson's disease, but if you took that drug away, they recovered again. So it was a big surprise when they began to look at the brains of animals, because they reproduce this phenomenon in animals. So you give a rat or a dog Thorazine, and they become rigid as a log, and they develop a very fast tremor. And the rigidity is so severe, you can pick up a rat with two fingers, with the nose on one finger and the base of the tail. It's stiff as a log. If you take away the Thorazine, the animal recovers and it's normal. So what Axelrod found, and this corresponded to an era when the development of assays or measurements of neurochemicals in brain was just beginning to be established in the 1950s. So one could take very tiny bits of brain, run it through a chemical assay, measure dopamine, norepinephrine, serotonin, and a whole bunch of other neurotransmitters. So that's what his specialty was. He was one of the pioneers in measuring brain monoamines. So he took these animals and found that, first of all, these animals given Thorazine were not getting dopamine to bind to the receptor. He found they were blocking dopamine. Secondly, he gave another similar drug called reserpine that was very similar to Thorazine, but it worked by depleting dopamine and norepinephrine, and that produced Parkinsonism. But he could recover the normal function in these animals by giving them levodopa, because levodopa then would replace the dopamine that was lost from reserpine. So he postulated, based on his animal work, by the way, this led to a number of things. He got a Nobel Prize for this maybe 15 years later. It led to the development of Cinemet. It led to the development of people not having to go to nursing homes so early. It led to the development of dopamine replacement. It all came from studies of drug-induced Parkinsonism. It's the one form of Parkinson syndrome that we can cure. In fact, when I started off and I was seeing a lot of patients in Miami, just in 1986, I remember, I saw a lot of Cuban refugees, older people with Parkinsonism, and so many people the age of my mother with Parkinsonism, and they're all from Cuba. I said, what's going on? And I realized that so many of them, because of their anxiety and depression, having to leave everything in Cuba, their local family doctors put them on Triavil, which was for agitated anxiety and depression. Triavil has two components to it. One is Elavil, which is an old-fashioned antidepressant, and perfenazine, which is like Thorazine, and that's the tranquilizer part. So, and that blocked dopamine receptors. So they had doctor-induced Parkinsonism. The kind family doc was trying to allow them to sleep, allay the anxiety, was giving them Parkinsonism. Once I realized that was a very popular drug in the Latin community in Miami, the word got out, don't use Triavil. I tried to tell the doc, don't use Triavil. And the reputation came that I could cure Parkinson's disease. I said, no. I can recognize drug-induced Parkinsonism. And you know, there are other drugs we use all the time. The other drug that can cause Parkinson's, especially if you're older, because as we get older, we have less reserve, dopamine reserve. So all you need is a little bit of a blockage of the dopamine receptor, and you can have transient Parkinsonism. And what is a common cause of Parkinsonism? Reglan, which was very popular and still used, metoclopramide to promote gastric emptying. Well, that has a side effect of blocking dopamine receptors and can produce, or if you already have Parkinson's disease, it's going to make it worse. Antiemetic drugs like Tigan, or there's a few others, they work by blocking dopamine receptors at the blood-brain junction, barrier junction, but some of it gets into the brain and blocks dopamine receptors in the brain and causes Parkinsonism. So that's drug-induced Parkinsonism. And finally, there are Parkinson's syndromes due to toxic exposures that we know can cause Parkinson's syndrome. One of the common toxic agents is manganese, that welders are exposed to, miners. In fact, manganese madness was described, manganese-induced Parkinson was described in about 18 years after James Parkinson described idiopathic Parkinson's disease. This guy named Cooper, an English physician, found that many of the miners, ore crushers, called manganese ore crushers, breathed a lot of the ore of manganese oxide, and they developed something that looked just like Parkinson's disease. But if you took them away from that environment, their symptoms would get better, up to a point. But if they were in that environment for a long time, even taking them away, they then continue to develop with Parkinson's syndrome and progress. And it's been a very controversial medical legal area, in fact. So battery workers, miners of manganese, welders, all have about 6-fold increased risk of developing Parkinson's disease. And so that would be, you can't say it's idiopathic, it's probably caused by the toxicant. That's just one. Then we know pesticides and herbicides. There you can cause the illness in an animal. It's hard to say it's the cause in humans because there's so many factors. Maybe some of the idiopathic, we don't know the cause. Some of these subtypes may be due to some of these environmental toxins. And finally, amongst the idiopathic, that shouldn't be idiopathic anymore, is the genetic mutations that increase the risk. There's probably only 2 genes that definitely result in Parkinson's disease in a family. So that we would say is hereditary Parkinson's disease. And it looks just like idiopathic. But idiopathic, if you don't know the cause, if you know the gene, then it's no longer in that rubric or garbage bag of idiopathic. So you see, it's a complicated story. And not only is it complicated, that now the neurologists had a meeting and they're arguing about, well, what really is Parkinson's disease? What really is idiopathic? Should we base it on the pathology in conjunction with the clinical history? It's very difficult because there are some cases of Parkinson's disease caused by genes, either Parkin mutation, which causes a young onset Parkinson's disease. Those brains of those people that have been looked at, they don't have Lewy bodies. They don't accumulate the Lewy body, and they still have the disease. It looks, they lose their dopamine, they get better on dopamine replacement, they look exactly like idiopathic Parkinson's disease, but they have a gene that's mutated called the Parkin gene. And that gene is involved in the formation of Lewy bodies. So that's proof that it isn't the Lewy body that determines the illness, because even if you don't have the Lewy body, you can still have the illness. So they develop young onset illness because the mutated protein that normally would be cleared and stored, let's say sequestered as a protective mechanism in Lewy bodies is prevented by the Parkin gene, the Parkin enzyme, which would take bits of the toxic fragments of alpha-synuclein and would be stored in or sequestered into a protective sequester. Those patients without Lewy bodies develop the illness. I hope it's clear. It's another reason why just developing antibodies to alpha-synuclein is not going to be necessarily the answer. Also, there's one that's called LRRK2. Here's another mouthful. So I say them so I don't forget. You have to forgive me. If you don't repeat, you forget. Even if you have a good memory, you can have a fantastic memory. If you don't repeat things, it's going to go. So LRRK2, what the heck is that? It's a leucine-rich repeating kinase 2. Yeah. So it's just an enzyme. It's a gene that encodes an enzyme. And many of the cases of individuals who have that genetic mutation develop Parkinson's disease. It's familial, and they don't have Lewy bodies. So that because of that kind of information, people are wondering, well, why do we have to rely on the presence of Lewy bodies to call it idiopathic Parkinson's disease? And so there's a debate about that. So this whole area of Parkinson's disease there are those that like to synthesize it into one illness. The simplest way to do that is call it a Parkinson's syndrome, various subtypes, some of which have known causes, some not, some respond to dopamine better than others. That's the way to look at it simply. But if you're a real classical or neuropathology type, it's very unsatisfactory. You like to classify disease based on brain. But there aren't enough brain autopsies to really classify all the different forms of Parkinson syndrome. I think that's, see, you asked me a simple question. What was the question? I don't remember the question.
That was the question. No, I can see why you don't like that question. It takes a half hour to answer it.
Well, I like those kind of questions.
Now, I heard there was a show on recently about avoiding foods with gluten in it. Have you heard about that? Or?
Yeah, it's one of those buzz and popular things. It's amazing how things become fashionable. I don't want to make any comments on that. There's some people that truly have, a gluten intolerance, and they develop celiac disease, and that can create neurological conditions, especially cerebellar ataxias, myoclonic jerks. But I've never seen celiac disease, which is really serious intolerance of gluten, which is a protein produced in wheat. Okay? Some people have an allergic reaction to it. It causes almost like an autoimmune phenomenon that can affect the nervous system. But in all the cases of it's called celiac disease or gluten enteropathy. First thing they'll notice is a lot of diarrhea whenever they eat this, a lot of cramping, just poor digestion, malnutrition because they can't absorb the right vitamins. And it may be that the neurological features are due to malnutrition. Or it could be the antibodies that are cross-reacting, that antibodies against gluten that cross-react with some brain proteins. It's not clear. But Parkinson's disease associated with gluten enteropathy or celiac disease, I've never seen that. So it surprised me that on the web you'll see it. Now, what probably happened is there's gluten intolerance is pretty common, and there are various degrees of it. Only people that have severe intolerance should avoid a gluten-free diet, should avoid gluten-containing foods. I think that people would put on the web, yeah, I have Parkinson's disease and I have gluten intolerance, therefore it's associated to me, therefore probably that caused it. That's the kind of reasoning, and then that gets off in the social media. People tweet it all over the place, then you see it on the web, and then you start believing it. But there is no evidence that it causes Parkinson's disease. I think I have to do a few things. I have one more question, and I'll try to be brief.
DNA testing.
DNA testing.
Yeah, for your medications. Did you ever hear of this? I had it done. I didn't know the results.
Yeah, well, it's, with some medicines, there's the metabolism of one medicine will adversely impact the metabolism of a second medicine. So that's why if you're on a certain medications, you can see if you have certain inherited metabolic differences. So you could be a fast, high, or intermediate metabolism of. A good example would be just of alcohol. There are some people that are really poor metabolizers of alcohol, and they develop all kinds of issues, not just when they drink alcohol, but if they poor metabolizers, they're lacking a certain enzyme that would make it them more likely to become intolerant to other medicines that are metabolized by the same enzyme. It's that kind of thing. And it's called pharmacogenetics. The way we metabolize drugs is inherited in part because we have a whole host of liver enzymes that are involved in detoxifying small chemicals that we have in our environment. And sometimes there are mutations in those enzymes that make you unable to metabolize certain environmental chemicals. And those mutations also make it difficult for you to metabolize certain drugs. People don't realize this, but just as the immune system protects us against environmentally existing large organisms, I say large, like a bacteria or a virus, foreign proteins that you ingest or exposed to, your immune system has an elaborate set of mechanisms for dealing with these. These are relatively large molecules, the DNA and proteins in viruses and bacteria. But we're exposed to very small chemicals. In fact, we evolved on this planet along with all the plants that we eat all the time. And there's an incredible number of small chemicals in plants that our body had, some of which could be very toxic. We didn't have a way to metabolize them. So we've evolved a whole elaborate, in a sense, immune system, but it's called a metabolic metabolism system to break down all these chemicals. And every now and then there are mutations, just as there are in the immune system, that make it very difficult for you to deal with potentially toxic chemicals. So one of the big areas of research, and still continues to be of interest, has to do with the metabolism of pesticides, which are small chemicals that a lot of people can metabolize easily, but some people not. So, for example, dieldrin, which is a banned pesticide, banned since 1970, around the time DDT was banned. Well, dieldrin in animals destroys dopaminergic neurons. And I realize that dieldrin is found in all of our bodies because it's part of our biosphere. Can't break it down properly in the earth. And so I was measuring dieldrin in blood of cotton workers in Clarksville, Mississippi. This is a project I did in Miami. And there was a cluster of it means a high number of patients with Parkinson's disease who were farmers in the cotton business. And they hadn't used dieldrin since 1970. And then I got a group of farmers from that same community. I had a local doctor who identified these cases, who worked also throughout life in the fields or dealing with the cotton business, who didn't have Parkinson's disease. So we had about 30 blood samples from cotton farmers who had Parkinson's disease and cotton farmers who didn't. And in both groups, what I thought I would find is that dieldrin would be really high in the cases with Parkinson's disease and very low in those without it. Both cases had really high levels of dieldrin in their blood. Means even though they hadn't used it since 1970, this study was done in '87, they still had significant levels of dieldrin. The reason I looked at dieldrin is that when we looked at Parkinson's disease brain for a toxicology study, that's what I used to do before I moved into seeing what we can do to make cells grow rather than die, is dieldrin was found in very high levels in the brains of people with Parkinson's disease, but not age-matched controls. So I thought, well, dieldrin is still around. Maybe I should see if it's measurable in living people, not just in the brains. And so what we postulated why people exposed to dieldrin who didn't develop illnesses, they probably have, amongst their thousands of genes that metabolize chemicals, a better way of metabolizing dieldrin. So this is still what we were looking for. Why is it that some people in certain environmental exposures don't develop the illness and some do? It's just like infectious diseases. You can be around this environment where there's a lot of this bug around. Some people succumb and some people don't. Well, you have an immunity to it if you didn't get it, if you didn't develop the illness. So same thing with chemicals. So not only is there genetic factors, also it has to do with history of exposure. So if you've never been exposed to a whole bunch of plant chemicals in your whole life and suddenly you ingest some, they could be really toxic for you. But if you were exposed as a child, you can induce these enzymes. Many drugs that you take stimulate the enzymes that break down those drugs. That's one of the mechanisms for tolerance to a drug. So you ask a simple question. I made it too hard, I'm sorry. But yes, the question is that genetics of drug metabolizing enzymes can be tested for some of the enzymes, just a few of them. And it's certainly we do it all the time for people who are taking tetrabenazine for Huntington's disease. The company that provides the tetrabenazine is very worried about drug interactions because the metabolism of the tetrabenazine can be changed by the co-administration of another class of drugs. It's metabolized by the same enzyme. So at no cost, they do the assay on all the patients on tetrabenazine. And then if you see that there are fast metabolizers of tetrabenazine, then you can increase the dose to get an effect. Because if they're fast metabolizers of the drug, you're giving them a drug and they still have their chorea, because this is Huntington's is a chorea-inducing illness. So yeah, this pharmacogenetics is going to be bigger and bigger. So in the future, everyone is going to be genotyped for their capacity to metabolize scores of drugs. So that when you are going to be given a drug, say an antibiotic or a chemotherapeutic agent, they'll know what kind of metabolizer you are, and therefore adjust the drug dose accordingly. Right now we do it by ear. That's why I do a titration. Start with a low dose, build it up, build it up. But in the future, it's going to be like that, where blood sample, DNA analysis, they'll see what your pattern of drug metabolism is based on your heredity and exposure history. So it's like everything else. We are what we inherited and what we were exposed to throughout life. And I'll end it there.